Welcome back and good afternoon, everyone. Today, 123,135,920 persons have contracted COVID-19. My 79-year-old mom, Marlon Trotz, is one of them. She's currently in ICU battling the virus. And throughout this workshop, I'll be checking in with her to say I love you and remind her to do deep breathing exercises. Our world has lost 2,714,606 lives because of COVID-19 today. The US accounts for 542,000 of those deaths. A country with 4.25% of the world's population accounts for 20% of deaths worldwide from COVID-19. As a Black woman in the US, I'm accustomed to statistics like this for people who look like me. 13% of the US Black population, 13% of the US population is Black, yet Black people account for 38.6% of the prison population, and less than 2% of Black faculty are in science, technology, engineering, and mathematics. Black wealth is 10% that of white wealth. And if you are a Black person, you are 1.4 times more likely to die from COVID-19 than if you are a white person. Over the past year in the US, we also witnessed the murders of George Floyd, Breonna Taylor, Rayshard Brooks, Daniel Crude, Ahmaud Arbery, and many other Black persons. Most of us are unpacking and learning about the role of structural racism in the inequities that we see around COVID-19 in the US and elsewhere in terms of who can work from home, who can attend online classes, who cannot afford to buy food, who is being evicted, and who is dying more than others. While race plays a major role, so does gender and other intersectionalities. Many of us are challenging our own systemic biases, those within our institutions and those that perpetuate from colonized past. Last summer, Dr. Yvette Pearson introduced me to the concept of a Jedi culture, one where we champion justice, equity, diversity, and inclusion. The hard work that we must do to cultivate a Jedi culture requires that we listen to, learn from, and reason with each other. We hope that this NSF-sponsored Human PIP workshop provides the space to do just that and emphasizes the importance of the human component in all that we do as scientists and engineers. It feels surreal to be doing this given my family's current battle with COVID-19. I am in day 10 now of quarantine. And coming out of my bubble in Tampa to visit my mom in Guyana, who had a separate illness prior to COVID-19, was quite a reality check, as this virus has taken a toll on our elders. It was also an eye-opener for the conversations with taxi drivers who asked if I believed in God when I questioned why the mask was on the chin, and to witness vaccine rollout in a country that has to date only secured full doses for 24% of its population, the majority of which have yet to be delivered. For this session, and I'll share my screen now, it gives me great pleasure to moderate this session on equity, access, and community engagement. Like this morning, we'll have 4 7-minute speaker presentations followed by some moderated discussion and Q&A. We'll take a short break and return to the Zoom session to go back to our mural boards, and our final wrap-up will occur in that Zoom breakout session. John, did you have anything to add?
No, at the end of the day, we'll just show you some of the other mural boards. We won't have obviously enough time to dive into everything like the team will after the fact, but we'll end the day by just seeing some of the ideation that's already being generated and any other closing remarks. One thing I would like is any of the panelists today at the end. First of all, thank you for joining the breakouts. I wasn't expecting that, and I think that's really lovely. So an idea I have towards the end as well is if any of the speakers at the end of the day want to say anything based on what they've observed in breakout rooms, I think that'll be a generous thing if you feel called to do so. But that's it, Maya. Thank you.
That would be great. Thank you. And so let me introduce our speakers for today. We have Dr. Sisuneka Ivy, who is an assistant professor of chemical and environmental engineering at the University of California, Riverside. Her anchor talk has been placed on our YouTube channel, and so she'll be doing a shorter version of that today. Dr. Eugene Richardson from Social Medicine and Global Health, an assistant professor in the Harvard Medical School. Enbal Shekam, who is a professor in the College for Public Health and Social Justice at St. Louis University, and Boji, who's a professor in the School of Nursing and School of Information at the University of Texas, Austin. I will now ask Sisuneka to lead us into the first presentation. And if you just tell me to go to next slide, I will advance the slides for you.
Wonderful. Thank you, Maya. And thank you for inviting me to give the anchor talk today. And I've enjoyed this session so far. So I look forward to talking to you guys about the abridged version of my YouTube video. So I'm highlighting one of the articles from the LA Times that looks at the vaccine inequity that's pretty widespread across Los Angeles County, where the vaccination rate for whites and Asians exceeds that of Native American, Latino, and Black populations, while the death rate and the case rate is actually flipped for those demographics. Next slide. And as I did in the YouTube video, I'm highlighting the income versus cases versus death versus vaccination. Is there a comment? Okay. Discrepancy in those data as well. I'm comparing the community of Paramount and their income versus their case and death rate versus Palisades Highlands. And you can see that there's clear inequities in the vaccine distribution, which is quite troubling in that we've been one of the epicenters this entire time. Next slide. And so I'm highlighting here how the COVID-19 pandemic and its disparities, those disparities cascaded across a number of different sectors in terms of lost wages and who was able to work versus who got laid off, who were able to retain health benefits versus who weren't able to retain those benefits, who was represented in the vaccine clinical trials. And this reflects a lot of the themes that we discussed in the last section in regard to messaging and trust and beliefs. And so I think that is really important for that part of the COVID-19 impact. And in an intersectional cluster that I was a part of, we saw that maternal morbidity was also the worsening of maternal morbidity was also seen across the pandemic. And this last bottom right corner is saying that all of these disparities were pretty much amplified across the BIPOC communities. Next slide, please. I'm highlighting from another LA Times article. Very early on, it was seen that the COVID-19 case rate disparities overlap with the environmental disparities, and the environmental data comes from the Cal Environmental Health Office, and the data are Cal EnviroScreen results. So it's a weighted average of overall vulnerability due to environmental disparities, and the case rates and the environmental disparities line up. And I just want to let you guys know that these places are not too far apart. And so I'm going to talk about why we see these sharp gradients and disparities in just a second. Next slide. So in my own local study, we were looking at the data for Western Riverside County. So this study was led by Jade Sasser in the Gender and Sexuality Studies Department at UCR. And so it was a highly interdisciplinary effort to look at what are the overlapping causes, effects of the COVID-19 disparities. It pretty much came down to race and ethnicity. And I pulled out the fact that land use can also be a good indicator for how we identify which communities are going to be most gravely impacted. And so what we highlighted from our study is that our essential workers here in the Southern California region, not only are they at higher risk for having to work, but where they live and their vulnerability is both environmentally and socioeconomically mediated. Next slide, please. So particularly where I live in the Inland Empire near Riverside, California, the local decisions on land use have had pretty grave consequences for environmental vulnerability. And so I didn't realize this before I moved here, but parcels next to communities are highly frequently upzoned for commercial and industrial land use, as you can see here on the left, with the proliferation of warehouses right next to this community. And on the right, there is a natural gas bus refueling facility right next to one of our underserved communities in Southern California. Next slide, please. And so in my talk on YouTube, I talked about a study that I conducted where we were actually trying to quantify air pollution exposure disparities. And it pretty much corroborated the initial hypothesis and the lived experiences of the people that live there, that our poorest community that we studied had the highest fine PM exposure. And this was a wearable monitoring study. And so I linked this to land use practices and the fact that multi-generational compounding impacts of isolated and confined residential spaces are really important for understanding how land use practices cascade into public health and other various disparities. Next slide, please. And in my last slide, I'm going to talk about the calls to action that I brought up in the video. Number one, essential workers and their households should be the target of these concentrated pandemic prevention resources due to the overlapping nature of environmental and socioeconomic variability, disparities. This is in the form of making sure that they have health benefits, vaccines, they're able to take off work when they're sick, and PPE. I know someone mentioned, I think Jamie mentioned that we don't need big data, but I'm going to make a plug for big data and Internet of Things and accessible connectivity in communities. I think that we can learn a lot from especially concentrating at connectivity in underserved communities. And number three, I'm posing a grand challenge in that actually trying to reverse the environmental and health impacts of systemic inequities, that's our grand challenge as engineers and scientists. And these solutions need to be innovative, scalable, and cost-effective. Thank you very much.
Thank you so much, Sunny and Dr. Ivy. And we will move into the next presentation by Eugene Richardson.
Okay, thanks so much. I'll be talking about reparations and COVID-19. So following on Dr. Ivy's excellent talk. Next slide, please. And I have no commercial relationships to disclose. Next slide, please. So as she mentioned, the 21st century grand challenge to reverse the environmental and health impacts of systemic inequities with innovative and scalable solutions. So if you look at the grand challenge of the 1900 or the 1800s, for progressives, that might have been abolition. And for the 1900s, you could look at it as the human rights century and global development aid, all those kind of things. And I think for the 21st century, to achieve these goals, we have to move to a notion of reparative justice. And as such, I chair a commission for the Lancet on reparations and redistributive justice, which I'll talk a bit about. Next slide, please. I also have a book that just came out that explores these issues on how essentially what we call public health science has racism and coloniality built into it. And so the project I'm going to talk about is an ancillary study to this. Next slide, please. And in what's coming, I use Ibram Kendi's definitions, race, a power construct of collected or merged difference that lives socially. And race's policies or analyses, I'll add, are any measures that produce or sustain racial inequality or inequity. And an anti-racist policy is any measure that produces or sustains racial equity. Next slide, please. So for an example, I've been harping on these Institute of Health metrics and evaluation COVID models, which have not only been wrong, if you look at what they were predicting last spring, and not were not only used ideologically by Trump et al., but next slide, please. You could also see them as racist because by the Kendi definition, even if they tell us to wear masks and socially distance, we're still going to see, we might have less infections, but we're still going to see that disparity, which was mentioned earlier, 1.4 times the death rate. None of these models really include in their social imaginary racial justice interventions or interventions into risk structure. And in so doing, they actively delimit through exaggerated precision and acceptance of government interventions as status quo, the public's ability to imagine social alternatives. Next slide, please. So to help imagine social alternatives, we've colleagues of mine formed this commission. And next slide. One of our ancillary projects was we just published a paper in Social Science and Medicine, what we thought of might be what anti-racist modeling might look like. And you can see Jamie's the senior author here. It's entitled Reparations for American Descendants of Persons Enslaved in the US and Their Potential Impact on SARS-CoV-2 Transmission. Next slide, please. So as we've discussed that, Black Americans and other people of color are suffering from a significantly disproportionate incidence of COVID. But going beyond the mere epidemiological tallying, the potential for actual racial justice interventions, they've been rarely explored. And models must make assumptions about how people interact with others, but they rarely account for social forces like institutional and cultural racism that structure such interactions. Therefore, they can obfuscate such forces. Next slide, please. So we define reparations as an acknowledgement of a grievous injustice, redress for that injustice, and closure of the grievances held by the group subjected to the injustice. Next slide, please. And I'll just go through these quickly. I'll refer you to the paper if you're interested. But essentially, we considered a range of reproductive ratios when we use the next generation matrices to actually back calculate beta or the transmission rate. And in doing so, we showed or we postulated that, next slide. And here's the next generation matrix. It's all in the paper. Next slide, please. Oh yeah, Jamie put up the link. We basically show that much of the risk, and we used Louisiana for an example because of its availability of COVID data and because it has segregated groups of white and Black populations, but not much other minorities. So we could do this binary analysis, and a lot of the risk just comes from when we're seeing these higher death rates. They're not from these Black fragile bodies or vulnerabilities. They're actually from risk of infection. And so just based on overcrowded housing and frontline work alone, we were able to postulate that, next slide, please, reparations payments paid 5 to 10 years ago. And we use the amount that Sandy Darity at Duke University has come up with, which is essentially a figure to eradicate the wealth gap between Black and white people. And that amounts to about $200,000 per descendant. We found that just by having introduced reparations and affecting housing, risky housing and frontline work, that are not for the entire population could have been reduced by 30 to 68%. That such a restitutive program not only decrease decreased transmission among the recipients, that because the highest risk group comes to dominate what R0 is for the whole population, would actually, the benefits would be distributed across the population at large. Next slide, please. And here we see just going from an R0 in the 4s down to 2, just by getting transmission rates in the Black community to near parity with what they are in the white community. Next slide, please. The mechanisms could be narrowing the path-dependent racial wealth divide, changes in the built environment, which also foster the ability to social distance. Frontline work would be spread across racial groups, and then a decreased race-based allostatic load. Next slide, please. And we conclude that since reparations had not been enacted, and we wrote this back in April, so we predicted that reopening American society early would have a disproportionate adverse mortality effect on Black people. In fact, that was predictable. And so this is kind of a contemporary Tuskegee. And the appalling evidence of racism embodied as disproportionate COVID-19 incidents and mortality for Black Americans should add to moral, historical, and legal arguments for reparations for descendants of people enslaved, as if those weren't enough. Next slide. And this got covered in CNN, and we've received loads of hate mail. Next slide. So thank you. And if there's any discussion afterwards, feel free to email me.
Thank you, Eugene. And now we will move on to Enbal Shakem.
Hi, everybody. My name is Inbal Shakem. I'm a professor and associate at the College for Public Health and Social Justice and the Associate Director of Geospatial Institute at St. Louis University. I wanted to thank NSF and this great group of people organizing these panels. It's been already such a great honor to be a part of this. Next slide, please. So I'm going to talk a little bit more about geospatial health and the angle of, and the lens in which I study both COVID, but other disease, both health conditions as a whole. And so what we know about COVID has already been outlined in the first two great speakers, but particularly that I'm focused on is we knew from the beginning that urban communities were going to be at the highest risk at the start. And also now through strains, they're also at the highest risk. And you can talk about rural communities having other types of risk, but this is really important to think about where infections are coming and how we predict and respond to the next pandemics. So international airports, right? So people who worked at international airports, they went to their employees, right? And they went to their home communities and they were exposed to COVID at work. And then they went home and they were exposing their families as Eugene highlighted, through overcrowded housing, and then thinking about how to respond to the need of COVID prevention, testing and treatment. We were way behind. And so this is an opportunity for us to say, how do we do this better in the future? How do we, how do we create policies that actually work to reduce inequities? So it's a location focus that needs to be prioritized in ways that many places throughout the country in the United States and throughout the world have not used and utilized that and leveraged that opportunity. So I'm going to talk about two of our recent studies that I conducted with my colleagues. Next slide, please. And we really looked at how different policies had different outcomes. So inequities using mitigation strategies. So the stay-at-home policies, next slide please, that were enacted last year, about this time last year, and that through May in our region in St. Louis City and County, really identified an opportunity for us to understand what is it that what was causing the infection rates to go up in our poorer neighborhoods, in our neighborhoods that also happen to be more likely to be African-American and more likely to be lower income. So we were trying to figure out what were these characteristics and what were the behaviors in those places. So much like Dr. Ivy's talk, we looked at this in another lens. We used different data to respond to these challenges, where we were able to identify using anonymized smartphone data, which is using big data, but really to identify the idea of how our communities and measure how our communities moving around in the context of COVID-19 and a stay-at-home policy. So we were able to identify that people were leaving their homes for full-time work even during during the stay-at-home policies in our region. Next slide, please. And this is where our this leave for home also highlighted the leave home for work, were also highlighted with the relationship with higher COVID rates in these communities, right? So no real surprise, I'm sure, to Dr. Ivy, but here we are looking at another form of data that was able to identify there are patterns of mobility and people moving around their communities that were able to identify that people were more likely working in healthcare support healthcare support environments, food service environments that had to leave their homes during a stay-at-home policy. And then we looked to see about the daily average change of they were leaving home, and then who was able to go back to work? Did they go back to work? So we looked at those patterns of employment. We looked at how and the relationship to community mobility as well as COVID. Next slide, please. So in quick summary of the stay-at-home policies, what we found were that people were unable to stay home. Our employees were at highest risk, were more likely to be hourly wages, non-professional positions. They were working in food service, like I had suggested, and healthcare support. So like the hospital support staff, not professional support staff. And so thinking about the role of essential workers this was another method to identify these are also essential employees put at highest risk for COVID-19, not given PPE, not given access to good testing or promoting the incentive to test for COVID because they couldn't take the paid sick leave as well. So then we looked at what does a mask mandate look like and how does that affect a community? And so next slide, please. We've implemented a mask mandate in St. Louis City and St. Louis County in July. And so we wanted to see how long it would take and did it have an impact on new infection rates. So what we found was over 3 weeks, we controlled from the period before and the 12 weeks after. We measured specifically here that I'm showing you, but we have 2 counties that did have an implementation of a mask mandate that were higher concentration of total population as well as population density. And furthermore, more often higher population of African Americans in this region. What we found was that the mask mandate worked, dampened new daily infection rates about 40% over that 12 weeks. And the infection rates did not go down in the counties nearby. And so this pattern has persisted over the last several months, and we have been able to identify that if what we think, we'd hypothesize that this type of policy has a better outcome of creating more equity in those environments, so people aren't exposed at the same highest rates or are more equitably exposed, if you can imagine, to COVID-19. Next slide, please. And this is also just counties with no mask mandate, the counterfactual of what we expect, of what would be expected, and then the counties with mask mandate. The dotted lines are the lowest rates, and the solid line is the highest. And so what we were able to see that there was this was a tangible non-pharmaceutical intervention that required support from our county executives and our elected officials, but also from businesses and the community members. We also got a lot of hate mail, probably not as much as Dr. Richardson, but you can imagine that also happened here. Next slide, please. So what we were ultimately saying and finding is that we still need to address employment policies. This is now consistently reported in your three speakers thus far of this section. But what we're really saying is, well, how do we create an environment where people can be employed and employment is a protective factor? Historically, we have highlighted how employment is a protective factor for health outcomes. But when you create a work site that is not healthy or not supportive of human flourishing, we won't have that opportunity. So big policies like the federal minimum wage, having paid sick leave, access to PPE, testing, healthcare access, quarantining as an option. This wasn't even really explored as a real option for low wage earners. And so how do we do this? One of the pieces that we hadn't talked about very often also was in nursing homes. We didn't have infection control training or specialists on board. So that was one of those, I think, is kind of a tangible intervention that can be implemented without much policy change. The others require significant policy change that should be continued to be sought. The other piece of this is that in response and really thinking about the grand challenges, we need to complement our traditional sources of public health and healthcare data to really think about, based on the vast amounts of data that we currently have access to, or now are constantly being collected to about us and our patterns of movement and our ultimately everything we do is tracked, right? So if we can use those data, harness those data for a greater good, thinking like, how do we better prepare and respond to having an early multi-sensor system that says this is predicting pandemics, right? So we would use and synthesize data that it's, whether it's anonymized smartphone data in addition to Google searches and Twitter feeds, and identifying where are people talking about how do we prevent and predict where the next outbreak will come. This is an opportunity for both technology and medical science to come together. Next slide. Thank you. So just thank you for my colleagues.
Thanks, Dr. Shakam. And now we have Dr. Boji.
Hi, everyone. My name is Boshi. I am a professor in the School of Nursing and School of Information at the University of Texas in Austin. I am very grateful for having this opportunity to present here, because I realize I probably am the only one here who's studying the older adult population. Am I right? So I'm probably the only the aging scholar here. My research over the past years has focused on the intersection of aging, technology, and health, specifically focusing on understanding how older adults learn to use new technology and how we can develop interventions to help older adults get access to the information they want in order to make informed healthcare decisions. Next slide, please. So last year, my colleagues and I, we developed this viewpoint paper published in the Journal of Aging and Social Policy. We argued that older adults are in triple jeopardy during COVID-19. Next, please. Yes, I use animations, so this will take a few clicks. The first, yes, thank you. The first one is older adults are more likely to develop serious conditions when infected by the virus. Also, older adults are at risk for social isolation, but especially the third point, older adults are less likely to have access to digital information or services and social interaction, because during the pandemic, when so much has transitioned online, older adults who don't already have the access or the devices or access or the knowledge and skills to use digital technology will risk further being left further behind. So we are arguing that really older adults are in triple jeopardy during COVID-19, that there needs to be special attention paid to the older population in order to ensure older adults have digital access to information services and social interaction. Next slide, please. What we are in another article my colleagues and I published was we try to argue that perhaps high-speed internet access should be considered a basic human right. And the reason we are really we are seeing this happening in reality, because over the past year, I have also been working with the local organizations who serve the older population to try to get technology to older adults. And there were cases where we got charged significant amount of money just so we could provide some mobile Wi-Fi access to our older adults who were so isolated. And then we realized, well, you know, maybe the companies should not be allowed to charge so much when people are during a pandemic trying to have that digital access so that they could human interaction, have some digital information. So it got us to think, well, it's much like water and electricity is so heavily regulated that you cannot just charge anything, because those are essentials. Maybe high-speed internet should also become an essential service. And I should also emphasize that the older population is very diverse, very heterogeneous. So far I have been talking about the older population as if it were one, but it is not. I mean, even just the age, in terms of age, when anyone say, I mean, the specific definition of what counts as an older person varies as well. A 65-year-old, their needs will be very different than a 95-year-old or other things equal. But the older population is very diverse, and we need to think about the diversity and try to develop interventions that would work best for individuals within the population in terms of age, health status, gender, race, ethnicity. Education also very important as well, income, of course. So it is very important to develop community partnerships. In my own work over the years, I have been working with the senior centers, senior living facilities, public libraries, including, I mean, right now I'm serving on this social inclusion task force, which is part of our Aging Services Council here in Austin. We have representatives from the state, from also the mayor's office, that we want to come together to make sure that we actually provide sufficient tech support and provide the technology, the devices, and high-speed internet access, constant tech support in order to make sure that people not only have the technology, but also know how to use it. And it is very tricky because in my own research, over the past 10 plus years, I have been working with older adults and various sites, public libraries, senior centers, for example, so that we could provide the instructions to make sure they would know how to use the technology. But suddenly during a pandemic, it's very challenging because we can no longer have the in-person interactions. But how do we teach someone who has not used a computer or an iPad or any other mobile device to actually know how to get onto it and how to set them up with Wi-Fi? It's incredibly challenging. Oftentimes I even wonder, it's like, does technology have to be so complicated for people who did not know? And how are we going to overcome this barrier where when we don't have the demonstration face-to-face, but we still will be able to actually help people learn how to use? And yes, please, the next slide. Oftentimes when I go to any conference that is not focusing on gerontology or aging-related issues, I get the same question. So I thought I might just throw it out here. The question could come in different forms, but ultimately it's asking, will generational digital divide or digital generational gap disappear on its own? The assumption I heard or justification I heard over the years was that, well, today's generation, we are more tech savvy compared with our parents, our grandparents' generations. So as we get older, when our generation moves into the older population, will the generational digital divide disappear on its own? Well, unfortunately, the answer is no, because technology is not a constant. As we age, so is technology. And technology actually ages at a much faster rate. So unless we provide specific interventions, unless we provide specific resources to ensure that our older population will be able to make the best use of what new technology can offer, there's always going to be this the divide and challenges. So I think having that mindset that we need the constant attention to the generational digital divide and the resource, incredibly helpful. All right, next, I think this is, yeah, okay, this is, I'll be happy to answer any questions you might have. Thank you.
Thank you to all of our 4 panelists. And I want to encourage those who are panelists. I understand you cannot type your questions in the Q&A. You may be doing it in the chat, but please feel free to jump on and also join the conversation. Before we go to the Q&A, I did have 2 questions to ask the panelists. And the first is, I guess Bo talked about her work with communities and community engaged work. And so curious to know how the others deal with community engagement as a part of the work that you do, like tips for others.
Be happy to just give a couple thoughts. Most of my work and training has been in community engaged, or at least, or community participatory research. So this has been a shift to looking at big data and how does it apply to people's health and livelihood. And so one of the pieces that has been consistently important for the work that we do has been feeding it back to community leaders, and then thinking about how they can use these data to help complement the work they do. So some of the work that we've done in our analyses has been shared and shown with county health department, both staff and leaders in that space as well.
Thank you.
Yeah.
Eugene or Sunny?
I have a few tips. I found that developing a really strong relationship with the community organizers that are in your local area, that really helps. And it takes time and it takes patience and a great level of humility and empathy to build trusting relationships with them. But once that is established, they open up a gateway to understanding what's going on in the community, what the barriers for communication are. And I found that to be really helpful for carrying out my community engaged research.
Thank you.
For me, over the past year, I was seconded to the Africa CDC to work on to support COVID containment on the continent, and they developed a vision back in February of last year on coming up with a continental response instead of the usual truncated NGOs aligning with ministries of health. A more Pan-African vision. And I found it difficult to, when I went back to the countries I usually work in West Africa, having to pretty much, stand up to some of the NGOs that are coming with their, we have the technocrats, we have the resources, this is how we want to do it. And, there's actually a more organic, homegrown continental vision that is different from the one being proposed by the global North technocrats. So sometimes it's being a good ally is having to confront your peers in what they think they're doing right when they're actually not listening to what's going on the ground.
Thank you. Bo, did you want to add?
Yes. Did you mean to add on the point of community engagement, or because I saw also a question in the chat about the caregiver? I mean, okay, I'll go with community engagement.
Yeah.
The model I have been using over the past 10 plus years I have found it very useful in the sense that I, as a researcher, I would be coming in trying to bring in funding from my funding has been coming from the NIH, specifically the National Institute on Aging, which has been tremendously helpful. And then I could focus more on the research aspect in terms of developing and testing systematic interventions that would help older adults, but we cannot possibly do it just by on our own. So we have been collaborating with local communities where we have this partnership where I would send in my team, my graduate students that I train, and then we go into the different sites. The communities, they would help us and host these events and help us to work together. But I think increasingly we are really developing even tighter partnerships in the sense that I'm also inviting my community partners to become co-designers in the development of our tutorials, the interventions we develop. So it's not just a matter of we do what we think they would need, but it's really inviting them to work with us as collaborators early on. So, and we also make sure to invite older adults into our design team so that we could develop tutorials, interventions that older adults themselves will want to use and they will find useful, and that the local community organizations will find it feasible. So it's been incredibly helpful over the years, but I think having the funding from federal agencies like NIA has been incredibly helpful.
Thanks. And a really specific question, how do you fund that community members to be part of your co-innovation system? Is it under participant cost, consultant costs?
Well, the model has been evolving into more sort of a tighter relationship. In the past, we were basically, I mean, it would be very modest in terms of we provide participant incentives, but that was sort of like a more, a less engaging model. But now I'm in the process of writing this grant proposal where we are actually having the community organizations written into the grant proposal so that they are going to be a part of the larger team, and they will be really working more closely with us. And their materials will be in the application, not just in terms of writing a letter of support, but we are really going into the depths in terms of talking about how we are going to work together to ensure that we are addressing a real community need. Because I mean, these are the people who really, they work on the front line. They really understand the needs and preferences of older adults. Often, like I'll give you one example. When we try to set up Wi-Fi access and older people's homes over the phone, I mean, take a guess how long that might take. It could easily take an hour to 2 to do this over the phone. Just to, if we send a tablet into someone's house, from the moment when they open the tablet to we actually set them up with Wi-Fi access, it could easily take 1 to 2 hours. If I'm talking with these community workers, they fully understand what the challenges involved, but it is often hard to talk with people, technologists, for example, people who have not yet worked with older adults. It is very difficult to get them to understand how challenging that might be. So I think working more with community partners will really help with getting the work done. But we obviously need the resource. In the past, we have relied a lot on volunteers. I mean, there are pros and cons of having volunteers, but still it requires resource in order to actually manage the volunteers.
Thank you. And so I will jump to and ask Alex and Heather. I think they have some of the questions that have been coming in. If you all can ask, and if you could just say who asked the question, that would be great. So I don't know everyone.
Sure, we'll just switch gears a little. We have a direct question for Dr. Ivy, asked via the chat from Christina Moya. In addition to upzoning disproportionately affecting already marginalized communities, there's the challenge of people moving to places with greater environmental hazards because of the coercion that comes with poverty. Do you have evidence that this happens in areas like LA with housing pressure? And how do we deal with that without more progressive redistributive efforts?
Right. Thank you to Christina. I was answering it in the chat. So I don't personally have the evidence that this is happening. I think it's a question mark that we could potentially be collecting data for. Relocation of residents from marginalized communities is an interesting phenomenon. Number one, we have to consider whether or not the disposable income and the job mobility or being able to get a job at your next place of residence is even feasible for these people that may want to relocate from where they're living. And more often than not, people are not going to move away from toxic environments because that mobility is limited by disposable income and all sorts of other things. But when people do decide to move, I think what we can do to perhaps make this more equitable is help community or help people to understand what's in their real estate documents. And so when you move, you get a document that talks about the existing hazards. And so if there were some mediation between the communities that may not be able to interpret those documents as well as someone that's well resourced, we could help them to understand where they're moving to and perhaps inform those decisions. I don't have the data, but it's an interesting question.
Anyone with the next question?
Sure, I'll just follow up. This is a general question for any of the panelists from, I think it's Preeti Zanwar, that was also asked in the chat. How does one go about examining institutional racism that applies to workers that may or may not be essential care workers? It seems many workers have been affected by this who may not be essential workers.
I think that I'm just going to go out on a limb here and say that the institutional racism affects everyone regardless of their employment status, and probably in different ways by their employment environment. So creating employment environments that are anti-racist by using anti-racist policies would create a better opportunity. I think we have so much more to know. It was just looking at through the lens of employment in the sense of COVID infections, and risk of infection was higher among those essential employees this time.
Okay, do any other panelists have an answer for that?
I think raising the awareness and also allow room for personal development is incredibly important. I myself, I can say that over the past year, I have developed so much. I certainly feel, I probably should develop even more, but it has become more clear to me, the institutional racism that we are facing every day, things that perhaps previously I was like, did not pay attention or thought it was part of the American culture, but it's not. It's not okay. There are a lot of things I think the year of 2020 really has been a year of self-development for many of us, and that's great. But perhaps there is a lot more we can do. And over the past several days, I'm just really so saddened by the tragedy happened in Atlanta, the senseless killings of these people. 6 of them were Asian women. And I think really there is a lot more we need to do. We really need to think about, we need to stand against the racism, to really work together to make this a better world for everyone, for our children, for our future generations.
Thank you, Bo. We only have 7 more minutes for Q&A, so could you guys?
Sorry, Maya, I saw questions, a couple of them particularly addressed me in the Q&A for the panelists. If I could just jump in and answer them.
If you can answer one and then we could shift to someone else. I don't think Eugene has answered anything as yet.
All right, just very quickly in terms of vaccination, why it's so hard for the older adults in our community. Because I mean, any of you, if you have your parents or grandparents who have tried to sign up online to get a spot, to get vaccination, it's incredibly difficult. I think a big chunk of that is missing is we have not been utilizing the already well-established community organizations, because there are a lot of local organizations whose mission is to serve the older population. They've been doing this for years, for decades, and yet they are totally not in the picture. What we should have done is to realize that the older population who is really in need of the vaccines, these are the people we should not be counting, should not be thinking we should reach them over the computer or even a mobile device. Call them from the organizations that they are already familiar with, the senior centers that they've been going for years. They know each other. There is this trust, this rapport that we need to really utilize. And I think that is a critical piece that is really missing.
Okay, thank you for that. We have another question from the chat for actually Dr. Richardson, asked by Monique Mulder. And she points out that Dr. Richardson, raised interesting and real issues of communities getting multiple, often conflicting advice or recommendations. And he was talking about West Africa. How true is that in the US?
Yeah, thanks for that. I mean, this allows me to shamelessly plug my book some more, because that's essentially what it's about. That what we call public health expertise, I don't even like the word, because anything that, anything that has to do with predicting social phenomena is always laden with your initial ideological baggage. And so right now you could get any advice you want. You could go to the guys at Stanford, Jimmy's colleagues, not him, and find more economy or neoliberal friendly recommendations. You could go elsewhere and find like from our paper, more reparative justice laden recommendations. And so I think you have to see what the ideological underpinnings are of the expertise you're going after, and does it have a justice base? And that's why we've been trying to focus on recommendations or supporting people that really have like a racial justice component or an equity agenda to their promulgations or to their expert advice. Thanks.
Thanks, Eugene. I'd be curious to know what the experimental design looks like to put the $250,000, in an urban Black community, and see how that goes. I know there's some places, some communities that are doing reparations, one in North Carolina, but they're directly tied to housing. And so it's not like actual cash, to a person.
I mean, I've been taking my cues from Sandy Darity, who's supposed to speak here today. But and his is that these piecemeal reparations in North Carolina, California, Chicago are actually somewhat self-defeating, because they divide and conquer. Even if I think one of these was done every day, they wouldn't get to the 10 trillion for something like 800 years, or I forget how he calculated it, but it's something outrageous. And so we really need to focus on the federal eradication of the wealth gap. And then we really don't have good data on like what financial windfalls would do, but that's where we have to open the social imaginary, because right now I think there's blinders put on most of the forecasting we do. They don't allow for such interventions we found this in trying to get this paper published, and it took 10 places, and all of them were not, oh, your models aren't good. They were, this is too much to even consider. It's almost like racism built into peer review. So
we have 3 more minutes before we go to our breakout room. Do we want to take another question, or do any of the panelists or want to offer some comments based on the discussion that we've been having so far? I had one of the questions I'd wanted to ask was how, based on the presentations, how do we approach convergence in our research with each other more? I think some of you have already connected based on looking at the anchor talks, but what's needed to sort of do more of this work, since it's just a few of us at each university doing it?
Go ahead. I was just going to say it's going to take a boldness, because we as engineers and scientists, we don't like to go too far outside of our uncertainty bounds. But in order to create these innovative solutions to really these tough problems, I think we're going to have to step outside of our comfort zone and work with people in front of whom we're going to sound a little bit silly. But it's a learning curve, and I think we can overcome that to solve these problems.
I would just add to that is our institutions and our funding structures also need to support us to do this really radically collaborative efforts. And I think this seems like a really great step forward for NSF to lead in this way.
Thank you. And we will have all of the questions that are not answered, and we'll try to get them answered by you all and placed on our website.